Hi, everyone. It's so good to see you all. Happy Thursday. Welcome to another VMR session, Thursday, Robbie and Charmin edition. We are so excited. Like always, we can't, I mean, we can't do these sessions without you. So if you have a case, please let us know. We would love to have you present, and we would love two people to talk medicine and have fun with us. It would be incredibly less fun without you all. So please volunteer, let us know. It would be awesome. I'm really looking forward to it. And before I hand the mic to the amazing Robbie and Jiha for some reflections on whatever topic his heart desires. I'm very excited about this. We would love your help. I actually put the feedback form in the chat. So basically, we would love to hear from you. We want to make sure CP solvers that we are doing justice to all of you guys' time. So if you don't mind giving us feedback on any of the CP solvers things you use, we would want to know how we can make it better, more useful to you all. So please let us know. The more we hear from you, hopefully the better data we have so we can make better decisions for you all. So thank you for taking the time to do that. I promise it takes less than 5 minutes. Looking forward to hearing from you. The one and only. Robbie, hi.
Hello, good morning. I will tell you, as I've said before, if you Google my name, you will find a much more handsome and successful human being than I. So the only lie that Charmin has ever told is that I am the one and only. In fact, there are many of me, and
Not in my book.
demonstrably more, demonstrably more successful and subjectively more attractive. At least I think so. Anyway. You feel free to Google that on your own time or right now, or you can use that as feedback to our CP Solvers product by saying that we promote random other Robbies for no good reason. Either way, all avenues are fine. Today, Charmin, this is going to sound familiar to Charmin because I had the pleasure of co-discussing a case with her. Simone, it's not cool. I'm gonna minimize the chat. I had the pleasure of discussing a case with her that turned out to be a non-infectious condition, but the journey really took us on studying infections. And I think there's a deeper concept that you may not find in the textbook that emerges when you're part of 300 or so VMRs, which is the pattern of infections emerges. And that pattern is really understanding what it means to have a localized infectious process, like a staph abscess or a pneumonia or a UTI, versus a disseminated process like dengue fever or Staph aureus bacteremia. We talked a lot about the center of gravity of diseases on VMR, and most infections that we take care of in the hospital, pneumonia, UTI, cellulitis, hepatobiliary infections, C. diff, et cetera, have a center of gravity in one specific organ. Those are infections usually of commensal organisms. In stark contrast to disseminated infections, which are usually infections that come from the world. So you'll see and hear case reports of COVID being a respiratory infection, but you all now have heard or seen maybe the devastating consequences of COVID everywhere, in the brain, in the heart, the kidney. In fact, environmental organisms tend to go everywhere, and local organisms tend to cause local infections. So when we're entertaining a syndrome that has a local feature to it, like pneumonia, the odds are that it is a commensal organism like strep pneumo that has gone to a place it shouldn't go. And if you're dealing with a disseminated infection, the odds are that it's an infection from the environment, and your immune system does not have the ability or the familiarity with the organism, therefore can't contain it, therefore it goes everywhere. Now, why is this helpful? It's a helpful framework because it's not always true. Local infections can disseminate. You can have Staph aureus bacteremia, and environmental organisms can localize. So you can have influenza just affect the respiratory tract. But when you're dealing with a disseminated syndrome, the odds are either that a local infection is now disseminated, or you were dealing with an environmental process to begin with. This is what ID does all the time. This is the ID review of systems, where they talk to the patient about all the exposures they've had in the world. Now, the framework I'm going to give you is a way to organize all those exposures and to think about them systematically. And it's the 6 Ps, one of which is a fake out P, so I'll need your help. All right, you ready for the 6 Ps? This is in no reference, my dear VMR CP solvers friends, to the Ps I was talking to you about before in the back room, which I will leave as a private P. And Simone's eyes just popped out of her head. We were talking about my dog's pee, like urine, but now this is a different P. These Ps are infections from other people, infections that you get from pricks of mosquitoes or mites or shared needles, puddles that you swim into that are either man-made, freshwater, pets that you may have, that you choose to have, or that you are exposed to, plows that maintain the soil, and of course the fake out P, food, which is not spelled like that at all. But Charmaine will tell you that my spelling is abysmal, and so it could totally happen. So these are the 6 Ps for you to play around with when you're worried about a disseminated infection from an organism from the world. And I'll share more of this later, but this is a good place to stop. Thanks for hanging out. I had paid no attention to the chat because of Simone, exclusively because of her. So I'll ask you, Charmaine, to see if we have friends joining us today.
That was awesome, Robbie. I love how you just think about medicine, like think about like the way you explain things and you think about them just makes it more easier for me. So thank you. We have a case. Thank you so much, Donald, for presenting. And we have one discussant call in. So we need one more, team. Anybody else want to join call in the meantime? Donald, hi. Thanks for joining us.
Hi, everybody. I will disclose this is like my first or second meeting, so I may need a
Woohoo!
little guidance on the format, but I'll try my best with the a la carte and doing it appropriately for everybody's learning.
Yeah, we're just excited you're here. And thank you so much for presenting. And you'll do great, I have no doubt. The only rule of VMR is we need to have fun discussing medicine. So I think we can do that. Colin, how are you doing?
Hi, I'm good.
Can you tell us a little bit about yourself?
Sure. I'm a fourth year med student at UCSF.
Woohoo!
Been hanging out at home a lot recently. My biggest hobby right now is taking care of my COVID puppy, who I can have say hi to everyone.
Oh my gosh, that's so cute. I think COVID puppies are one of the best things that has happened over the past year.
Yeah.
So I'm glad you have a good COVID puppy. And congrats on almost being done with med school.
Yeah, I'm starting my sub-I at the VA next week. So I'm not on Robbie's service, but I'll be around.
Oh, that's awesome. I'm very biased, but I think the VA is just the best. So I hope you enjoy that. Donald, tell me a little bit about yourself too.
Yeah, so I am a recently graduated medical student. I attended the University of Queensland Auctioner Medical School. So it's 2 years in Australia and then 2 years at Auctioner Medical Center in New Orleans. I'll be starting my intern year at Henry Ford Hospital in Detroit, Michigan in surgery. So I've had this kind of, in this COVID time, a lot of time at home as well. And I have 2 boys. One who you may hear some noises in the background. So if I
amazing
intermittently,
that's kind the best kind of noise.
So yeah, I heard. So I'm excited to be here and kind of jump back onto the wagon. I've definitely been taking my time off and enjoying it before intern years. So.
You are a very smart man, Donald. You're very, very, very smart. Do we have any other volunteers? Yeah.
I think I may have seen Martine.
Oh, yay.
Discuss.
Martine, hi. How's it going?
Hi. I'm good. Thanks.
Tell us a little bit about yourself.
I'm Martin, and I live in Belgium. And for the moment, I'm in my last year of medicine and going through the selections for internal medicine.
Woohoo, that's awesome. Well, we have a surgeon, we have internal medicine, like the team is complete. And on top of that is Colleen. So that's awesome. So I can't wait to get started. Robbie, do you want to take the first aliquot?
Absolutely. Sounds good.
Thank you, team.
All right, Donald, take us away, please.
Yes. So for the aliquot number 1, so the chief complaint, shortness of breath and lower extremity swelling. All right. Do I just go ahead and jump to the HPI for you now? Yeah. So 39-year-old male with no known past cardiac history, and then presented with the shortness of breath, edema, and fatigue. A little more around this. Symptoms started about 4 months ago. He actually presented to the ED at that time and was found to have an unrevealing workup. And that included a normal chest x-ray. And then he was discharged with albuterol. He then re-presented sometime within this, from 4 months to present, to urgent care twice with cough, shortness of breath again, and fatigue. And still no diagnosis was discovered. Over the past week, he developed worsening dyspnea, orthopnea, requiring him to sleep completely upright, PND, paroxysmal nocturnal dyspnea, and peripheral edema. And then 2 days ago, his edema spread to his legs, scrotum, hands, and abdomen, prompting an ED presentation. I have some pertinent negatives that I can go over. He denies sore throat, vertigo, sputum production, chest pressure, discomfort, and then denies any history of palpitations and has never had a syncope in his lifetime. So I won't disclose that this was a patient that I saw on my internal medicine sub-I my 4th year last year. So it's an interesting case. I hope you guys enjoy it. Yeah.
Oh my God, we're already off to a tremendous start. I'm a little bummed, Colleen, that we don't get to work together in real life, and maybe we can practice going through medicine in the virtual space. There's a lot to digest here. There really is. And maybe, Colleen, you can tell us where you're inclined to start. Like if your mind's tackling this like fire hose of data, where are you inclined to begin to digest it?
I think when I see just a short HPI, I mean, obviously the first thing that would jump out at me is heart failure. I mean, shortness of breath has a much bigger list of things that I would think about first, but particularly the PND really screams heart failure to me. But without anchoring too hard on that, I mean, I think of I would think of the heart and lungs first, and then other things that can cause volume overload, problems with the liver or kidneys would kind of be the second place that I would go from there.
I couldn't agree more. I think that's superb. You've taken a very complex history and you've identified the features that allow you to zero in on the most likely diagnosis, which is you're saying, hey, there are many things that cause shortness of breath. There are many things that cause edema. The notable things are kidney, liver, and cardiac dysfunction, but the PND and the orthopnea are very specific to heart failure. And so I will give words to what you said. I'll give research level words to what you just said, which is that you don't want to anchor on the diagnosis of heart failure, but you seem to want to use that as a good operating framework. And I completely agree. You have to go down the heart failure route, but you cannot go down with blinders on. You have to be open to the possibility that this is heart failure and something else, or that this is something masquerading so much like heart failure that it really fools and should fool all of us until there's overwhelming data to suggest otherwise. So if we assume this is heart failure, and you've told us that two big mimickers are liver and kidney disease, which I think are perfect, how do you begin to digest that problem? Like, okay, let's call this heart failure, knowing that we might have to erase that in the future, but let's say it's on the board now. Where would you take it next? Like what would be things that you might think of as causing this heart failure?
So this is, I mean, usually when I would think of heart failure, I would think of coronary artery disease is a big one, but this is a pretty young guy, so I wouldn't, I'm not sure that that would be my first inclination here. I might think of something like maybe like a congenital valvular disorder or an infection that's infecting his heart, or maybe more of like an infiltrative process.
Yeah, I think that's superb. What you're doing there is you're teaching us that the base rate is the queen, and that no matter what, coronary artery disease accounts for up to 2/3 of patients with heart failure. So how do you factor in the other big modifier beyond the base rate here, which is the patient's age? And the patient's age forces you to consider things that present in kids, but then can have a delayed presentation into adulthood. And I think that's superb. Congenital heart disease as a large encompassing term is certainly something to have to think about here. So I think that you have to start with coronary disease. You have to use the modifier of the age and wonder, like, what do young people get? And what are causes of heart failure in younger patients? And those are certainly genetic diseases. Toxin-mediated diseases is not, older adults are not immune to toxin-mediated diseases, but the risk of alcohol, methamphetamine diseases is predominantly in younger people. I'd say a third modifier here is how quickly this seems to develop. Heart failure seems to have developed fairly abruptly in this gentleman. If you talk to people who have not had who are developing heart failure as adults, they usually have a much more protracted course. And how quickly he has gone from near normal to like having edema in his scrotum is remarkable. So I think we can use a couple of things. We can use the fact that this is a patient who's young as a modifier and wonder how that changes the landscape, and also wonder how does it change the landscape if it's happened so quickly. And those are questions I think we should leave to reflect on going forward. But to summarize what you've taught us, you said edema equals heart, liver, and kidney. Orthopnea is very specific to the heart. Coronary artery disease is the most common cause of heart failure in all comers. But there are two things that force us to challenge the base rate, and that is how young the patient is and how quickly the syndrome develops. And we'll see whether those questions move us away from the base rate, or they actually, the base rate is still dominant despite those being two unusual features. Alrighty, I think we'll leave it at that for now and go back to Donald for the case.
Okay, this is all really great, by the way, because hearing it broken down like this way, obviously, when I did this, it was like a med student scrambling to get all this together, but it's nice to hear it broken down and kind of revisiting it again. So for aliquot 2, past medical history, bipolar disorder, depression. The only surgical history is a tonsillectomy. And for medications, albuterol and diphenhydramine. And then for family history, he had a great uncle who died at 39 of a stroke, and another great uncle on the other side of the family who died at 47 of heart failure. And then the last relevant one for that is a grandmother with a history of AFib, MI, and stroke. And then for social history, he has alcohol use disorder. He also has tobacco use disorder, 15 years at 2 packs per day, quit about 10 years ago. Now uses electronic cigarettes. And the alcohol use is significant if we want more detail around that. But allergies is only sulfa. Okay. Then for exam, temperature 97.6, heart rate is 110, blood pressure is 126/92, respiratory rate is 18, and then saturation on room air is 96%. So, and then on exam, general, no distress. For HEENT, the JVP is elevated 3 centimeters above sternum. Cardiovascular is normal rate, regular rhythm, and intact distal pulses. No gallop or rub. There is a murmur, 2 out of 6 diastolic at the left upper sternal border. And then for poem, normal work of breathing, there are bilateral crackles heard, most prominent at the bases. And then abdomen is normal. And then for extremities, there is edema, 1 plus bilateral in the ankles present. Sorry, neuro, I skipped, it's normal.
All right, Donald, is this a good place to pause?
Yes, it's my understanding now. Now I pause for the next aliquot, right? So
Beautiful.
okay.
This is such a great case. Thank you so much for presenting. Martine, why don't we start with kind of like the background information to add on to the awesome discussion Colin and Robbie had. What are your thoughts about the background before we move on to the exam?
Okay, it's my first time, so I'm a little stressed, but no problem.
You're gonna do great. We are a
I'm,
team.
Thanks. I'm definitely worried about the familial history because there's obviously a lot going on a cardiac level, both with an uncle who's very young, and also the other members. The grandmother is already older, but still, you think there's something genetic or some problem in the family that says we should really look into the heart. About the meds, albuterol, I think it was started because of the shortness of breath. I don't see a real signal in here. The other medication, I don't know it, so I should look it up and see what kind of things it can do. The alcohol, I know that there is like relation with alcohol and heart disease, but I think is very young, and I don't know if the association is that big that we should really think it's the alcohol. So at the moment, I'm more thinking about the familial history than the alcohol as a component of the heart failure.
You're doing so awesome that you should just move on to the exam. What do you think of the exam?
Okay, the exam. Yeah, 97.6. I think in Celsius in here, but I think that's normal temperature. The heart rate is high, certainly for a young man. I don't expect those values. The blood pressure is okay, so for the moment I'm not acutely like I'm very worried. I think he's stable. Respiratory rate under 20 is okay, but still he's young, and I don't expect it. 96%, it's not really bad, but again, he's a young man. I should expect that it's a little bit higher. And clinically, yeah, objectively, he has too much fluid, so we are sure about that now. The crackles, I think mostly about water in the lungs because of the cardiac issue, so not directly something pulmonary. And then the murmur, left upper, I thought it was. So I'm thinking about the right heart, if I'm not wrong. It's during the relaxation phase, so I'm thinking about regurgitation of the. Yeah, I'm not really fast in thinking at the moment, so I'm just gonna pass it out. But I'm definitely worried about the pulmonary or the tricuspid valve. Yeah, and that's about it, I think, for the moment.
Friend, you're awesome. That was great. And I just want to point out that you made more progress about diastolic murmurs than I usually do. So kudos to you. And no, I 100% agree with you. And you pointed out all the important things that we should consider, right? You hone in on this family history of really like significant like coronary artery disease at a young age. So like having that genetic component of it, something we absolutely need to consider. And also, one of my favorite things is being like, oh, I don't know what this medication is, or I don't know what this thing does. So kudos to you for using my favorite phrase multiple times. Diphenhydramine is Benadryl, so it's like antihistamine medications that people usually take for allergies. And you hone in on the alcohol history, and with the exam, you painted a really good picture of someone who is volume overloaded, most likely in a setting of cardiac etiology. So I'm right there with you. A couple of additional thoughts that, whenever I see patients with significant psychiatric comorbidities, I don't see him on any medications for bipolar disorder. One thing that I do wonder is about the relationship with healthcare. And is a lot of, unfortunately, our psychiatric patients don't get really, really good medicine care. There's multiple different barriers. So I often wonder about like, hey, is this the patient that sees doctors frequently? Is this something that was brewing for a longer time that it came to the attention of medical services? And in terms of his significant family history, you nailed it. I think thinking about accelerated coronary artery disease, genetic components of that, given his family history, is going to be very important going forward. In terms of alcohol and cardiac disease, so alcohol with itself can cause like kind of like dilated cardiomyopathy. Another way that I think about people who drink a lot of alcohol is about what other deficiencies that they can develop along the way, with thiamine being one of the big ones. So like a thiamine deficiency can cause beriberi, can cause high output heart failure, can affect your vascular tone. So that is something to also keep in mind. I often ask them about their diet as well. And again, like the other things that alcohol can put you at risk for is kind of like AFib, as this patient's family member had, that over time can cause tachycardic induced cardiomyopathy type phenomenon. So those are like a couple of things to keep in mind. And again, like if there's any genetic component of this, thinking about like more genetic cardiomyopathies to going forward. One thing that I also always like try to think about is like endocrinopathy, especially in a younger patient that can present with heart failure, either thyroid issues, PO. Again, this blood pressure argues against that. However, these sometimes tend to be episodic. And like moving to the exam, and like elevated JVP, it's usually a good sign that we're dealing with a cardiac source of volume overload in addition to the crackle. So it paints a good history. I always like pause and make sure like, hey, I don't see any stigmata of liver disease, because then again, alcohol can also lead to liver disease, although this guy is quite young for that. But we don't see nothing is reported in terms of like physical exam findings of cirrhosis. So there's spinal angioedema, no jaundice. So that's good. And kidneys are usually the silent ones on the exam, right? Usually can cause anasarca, however, not really seeing that, and we just need lab finding for that. In terms of the diastolic murmur, it's just never normal if it's in the right side, left side. So the question is what type of murmur this is and how can it diagnostically be helpful? Is it due to like underlying dilated cardiomyopathy that you're seeing or is what we're seeing primary driven by a valvular disease leading to it? So like an echocardiogram would be really, really helpful. So I think at this point, getting more data to help try to figure out why this patient has a heart failure, and we'll go from there. Any other thoughts, Martin, before we move on?
Not really, no.
Great job, friend.
Okay, should I give some more aliquots? And I will say that the way that I'm going to present the next following two aliquots is actually how it kind of happened on the actual service. So there may be a little bit of a twist in the story, and I think it's important lessons to be learned. So moving forward, with that said, the CBC was normal. And then the sodium, sodium was 142, potassium 3.8, chloride was 102, CO2 was 29, BUN was 16, creatinine is 1, glucose is 84. And the calcium, phosphate, and magnesium were all normal. The BMP was 1574. And then HIV, we did an HIV test and a thyroid test. HIV was negative, thyroid test was normal. We also did a COVID test, it was negative, and UTOX was also negative. We did an EKG, and that was sinus tachycardia, left atrial enlargement, and no ischemic changes. The chest X-ray was non-specific, ill-defined bilateral basilar lung opacities. There is no large pleural effusion or pneumothorax.
A nice line here means something.
Hey, sorry to interrupt you. Hey, folks,
Yeah.
Saif, if you're listening to this, I think your unmute button keeps hitting. So if you mind muting yourself, that'd be very helpful. Thank you. And thank you for working so hard in the ER, like you always do.
Sorry, I didn't have the exact numbers for some of the others cast falls, but they were all normal. I can find them up if you guys want me to. There's one more here for this aliquot number 3. We did an echo, and that was reduced ejection fraction of 31%. Also severe left atrial enlargement, moderate mitral regurg, moderate aortic regurgitation, and a severely dilated ascending aorta, PA systolic pressure of 48. That was what I was thinking was good for aliquot 3.
Fantastic. Thank you so much. This is such an intriguing case. I will tell you that you all should listen to Colleen, because Colleen listened to the first aliquot, said, hey, this person has heart failure. And now we know this person has heart failure. So Colleen, if you had to summarize what progress we've made based on your initial hunt, where would you say we're at now?
I would say, let's see. So this is a 39-year-old man with a past medical history significant for early stroke in his family, who's now presenting with rapid onset heart failure.
Incredible. I love that you include the rapid onset heart failure as a key determining factor. And then in terms of trying to understand what may have caused the heart failure, what information are you latching onto to help you digest the heart failure itself?
Sure. So, one of the things that I was trying to kind of not ignore is the possibility that this could have been due to endocarditis, even though he doesn't have any super specific risk factors for that, but he's tachycardic, and I know that that's something that can cause valves to fail pretty quickly. Looking at his labs, given that his CBC was normal, I'm less concerned about that as a cause for this right now. And then I think between his EKG and his echo, there's a lot of really great information there. So the left atrial enlargement, the enlarged aorta, and the regurgitation on the left side of the heart is kind of definitely pointing towards left heart failure, and explains why his lungs are wet. In terms of cause, I don't know that I have seen really any instances of a dilated aorta, but that's making me think of something like maybe an aortic dissection, which I know I have to remind myself of the types of aortic dissection, but I know there's one type that can dissect back towards the heart and can cause failure of the aortic valve. So that's kind of where I am putting my money right now.
your money is well spent, and I'm right there in the aorta with you. And I think the question to ask in this case is, how do we know we're in the aorta? Because you look at that echo and you're like, oh, is the left atrium the problem? Possibly. Is the mitral regurg the problem? Possibly. Is the aortic regurg the problem, or is it the aorta? All those are enough to cause heart failure, but how do you connect the dots? You connect the dots by making an assumption. The truth is all of them could be affected separately. You could have mitral regurg for a separate reason, and aortic regurg for a separate reason, and aortopathy for a separate reason, but the most common denominator is to land on the aorta, but let's explain why. When you have multiple valves involved in a disease process, there are two diseases that commonly affect multiple valves. There's endocarditis, which can actually hop from valve to valve, multifocal endocarditis, and rheumatic heart disease can affect multiple valves at the same time. And so I love that you maintain the focus on endocarditis in this case, because that's something we'll have to exclude. But neither of those account for the enlarged aorta. Enlarged aorta is not a feature of endocarditis or rheumatic heart disease. So could this patient have a chronic underlying aortopathy and have had superimposed endocarditis? For sure. But is there a way to connect all these through the aorta? And the answer is yes. The most common cause of multiple valve issues is not endocarditis or rheumatic heart disease. It's that one valve has failed, and as a result, the proximal chamber has dilated because of the valve failure, causing the other valve to fail. So how does the story begin? The story may begin with the aortic valve failing for reasons we'll talk about. And then the LV gets so big that the mitral valve can no longer close, and there's your connection. How do you now connect aortic disease to a dysfunctional valve? And the connections are two-pronged. One is your aorta gets so big that it stretches the valve orifice. And so you have aortic regurgitation for the same reason that you have mitral regurgitation, which is the LV is so big it's stretching the mitral valve orifice, and the aorta is so big it stretches the aortic valve orifice. So the simplest connection would be to say this person has an aortopathy or aortic disease that has gone so bad it stretched the aortic orifice, made the aortic valve dysfunctional, then stretched the left ventricle, and therefore the mitral valve apparatus is now dysfunctional, and there you go. Everything just spirals from that. So then the simple question becomes, well, why does this person have an aortic disease? While you're doing this, you have to keep track of all the assumptions you're making, because this person could have an unrelated aortic disease and have endocarditis or rheumatic heart disease. But if you're trying to make an elegant explanation, you're like, it's all about the aorta. So what diseases affect the aorta? At the VA, I guarantee you that over the course of the month, you'll either see somebody, care for somebody, or learn of somebody who has an aortopathy who is an older adult. And that's the most common cause, smoking and hypertension. But this is a young patient, as you latched onto as a key clue. And what causes chronic aortopathies in young patients really is four genetic syndromes and one idiopathic one. And the four genetic syndromes are bicuspid aortic valve, which we have to be open to here because we may not appreciate the bicuspid nature on a TTE, Marfan's disease, Ehlers-Danlos, and then familial aortic dissection syndromes that cause an aortopathy. So we'll have to keep track of those four possibilities. And so the next key questions are actually to wonder, I think, is this a bicuspid aortic valve? And just look at the echo closer or get a TEE, or to ask yourself, the aorta is really big and floppy and extensible. Is the skin big, floppy, and extensible? And I think that analysis will take us far, with one caveat. We're assuming that this aortopathy is non-inflammatory. There are inflammatory forms of aortopathy like Takayasu's giant cell arteritis, and infectious aortitis, which comes in a whole variety of flavors from syphilis, salmonella, et cetera, but there's no flavor inflammation here. So I would say we're here in the world of aortopathy. And because there's no inflammatory signal, we're going to move the spotlight away from this, but entertain the possibility by getting basic blood tests and a sexual history. But I worry that we're here because of the patient's having a non-inflammatory aortopathy and they're young. Look for a bicuspid valve, see if the skin and the joints are as floppy as the aorta. And this is a rare syndrome that's not at play here for a variety of reasons. Okay, all right, back to you, Donald.
This is great discussion. Okay, and I forgot to mention up front, I had worked with Jack Penner on kind of breaking down this case to aliquot, so credit to him for kind of trying to make this flow smoothly. So this is my last aliquot number 4. So we did a CT chest with contrast, and it actually showed an aortic dissection of the entire aorta, starting at the aortic root and extending to the common iliac artery. The dissection involves the origin of the great vessels of the neck. At this point, the TTE was reread, and an abnormal flow was seen in the descending aorta, suspicious of the presence of a dissection flag between the false and the true lumen. And I will add the context for that was, as many of you guys know, when you guys round and you prepare your notes for presentation, you would just read what the radiologist read on the TTE. The reread was done on the morning rounds with the cardiologist present. So that was how it was reread. That's my last aliquot. And so the final diagnosis is a subacute Stanford type A aortic dissection. So
Whoa.
yeah, it was so that's the little bit of the twist that I was mentioning, because when I first told Jack about it, I was like, should I talk about the reread? But I think it's important to put it this way, because essentially this whole discussion was done how we did it on the wards. So now, just to give the full story, this was a patient I saw when I was on cardiology clerkship. So they had consulted us for the low echo that was done. And so we kind of actually had thought a lot of what we discussed, the alcohol use disorder, we actually had pinned it a lot on that. We thought it was alcoholic cardiomyopathy, young person, massive drop in the EF, until the imagings and all that. So what I did not know was, I guess in medical school, you learn about type A dissections and they're a massive rush to the OR, like right away. I hadn't really been too familiar with these subacute variants that can be there for a long time and extend all the way down. And I was fortunate enough to follow the patient into the OR and see them do a procedure that involves something called like the frozen elephant trunk and replace a lot of the branches of the aorta and stuff. But
Wow.
so this is my interesting case. I hope you guys enjoyed it.
No, this is such an interesting case, Donald. Thank you so much for presenting. Any thoughts as to why this patient had aortic dissection?
We're not sure. So when it was discussed again, we thought that, the 4 months ago may have been kind of, this is the chronic course of it. It probably started sometime along then, and it was a minor dissection that just allowed it to kind of clot up and be there. I actually tried going back and looking to see some of the connective tissue disorder tests they might have done, but we didn't, nothing turned up. So, I found only really case reports for idiopathic variants cases of this. So I don't know if, as often is the case, sometimes you don't have it, you don't know the why for it.
Yeah.
Yeah.
Yeah, no, thank you so much. This is such a fantastic case to think about. And yeah, Carolyn is asking a good question about what causes this type of dissection in a young patient. I'll tell you as much as I know, and then I'll pass it to Robbie. I think in all comers, like aortic dissection, hypertension tends to be the most common. And in the younger patients, like connective tissue disorders, as Robbie mentions, like Marfan, Ehlers-Danlos, there's a couple of other, like this is a man, but like pregnancy, you can see it. And the other association that I have in my mind is like fluoroquinolones. I don't know what type of dissection it causes, but sometimes as a side effect, it can cause aortic dissections. I've never actually heard about the familial aortic dissection that Robbie mentioned. What else would you add, my friend?
That was wonderful. That was really, really good overview. I'll just tell you, maybe visually walk you through this world. So if you see an aortic dissection, the vast majority of people have an underlying normal aorta. So most people dissect on an aorta that has no abnormality to it. Here, you've dissected on an aorta that is massive and large. A dissection shouldn't make the aorta large. It makes it have a false lumen, but for it to balloon out tells you that there's an underlying disease that often needs to be discovered. And in patients who have an abnormal aorta on imaging, The key question is it inflammation or not? And that can be gathered both by history, labs, and imaging. So there's no, on your CT down, there was no evidence of an itis and aortitis. And so most in older adults, most people have a hypertensive aortopathy that Colleen will see for sure next month. But there are genetic aortopathies. And when we don't find a secondary culprit, it often is actually labeled as familial idiopathic aortopathy. And so it's non-syndromic, meaning that you don't find anything else outside, and it's an isolated connective tissue disease limited to the aorta. But I think the most important thing, quite honestly, is to make sure you're not dealing with a bicuspid valve, which I'm sure was considered here, because if you go in and you operate and you then discover that there's a bicuspid valve you need to fix too, you have to go in and reoperate, which is a problem. So of course, genetic counseling is really important in all these patients, Marfan's, Ehlers Danlos, whatever you have. So all these patients, you'll have to talk to them about genetic counseling. But it's especially important to tease out the bicuspid patients because they require, in addition to genetic counseling, the consideration of actually fixing the bicuspid valve, which I'm sure no CT surgeon would ever operate on somebody without thinking of that. So I'm sure that was considered and probably ruled out in this case.
Boom. Thank you, Fred. That's awesome. Martin, Colin, you guys are fantastic. Thank you so much for chatting with us. Please join us again. You guys are awesome at clinical reasoning. I can't wait to discuss with you again. And Donald, this was awesome. Thank you so much for sharing. Thank you for joining us. And I'll pass the mic to the wonderful Sukriti, and I'll put the link to the feedback form again in the chat. If you guys have 5 minutes to fill that out, that would be awesome. Thank you all so much. Sukriti, take us away.
Thanks, everyone. This is a really great case where we started off with a lot of data. And I think something that we learned from Colleen, Rabi, Sharmeen was to, when faced with multiple symptoms, to look for clues to form an operating diagnosis. And as Colleen mentioned, anchoring on a diagnosis too early could be a potential pitfall. So what we did was to identify what were the most revealing in terms of helping us frame an operating diagnosis. So we found that the orthopnea and the PND was more specific to heart failure, and the dyspnea and the volume overload, though concerning, had a really large differential. So it was hard to pick something out to help us carry forward this case. The second thing that we did was use base rate, and how base rate helped us prioritize coronary artery disease and heart failure, but then using age and the rapid time course as modifiers, and age could be revealing for childhood disease with a delayed presentation, and then really thinking about why this patient would have a rapid time course of worsening of his heart failure. We then went on to receive the past medical history and physical, which essentially helped us to look for clues. And as Sharmeen taught us, the psychiatric comorbidities helped us think about whether this patient had access to healthcare and what was his relation to healthcare. We also used some of the past medical history and the family history to think about etiologies that could be causing heart failure. So entertaining alcohol causing thiamine deficiency, dilated cardiomyopathy, atrial fibrillation, a possible endocrinopathy in a young patient, a genetic cardiomyopathy is given his family history. And then we really got to the physical, where we were able to say with almost certainty that this was a cardiac problem, because the JVP was a good indicator of a cardiac pathology, but we were also looking for whether there were any stigmata of liver disease. And we couldn't make too much progress about whether this patient syndrome involved the kidneys, because the kidneys are usually silent on exam, so we'd have to wait for the labs. But at this point, we were really thinking about why is this patient having heart failure, and trying to investigate that when we received the labs and imaging. And our pivot was essentially the echo and the TTF, which said that there was involvement of multiple valves and a problem with the aorta. And I think something that Ravi does that I really like is he creates these Venn diagrams, and he says that use one Venn diagram of which you know the framework of with relative certainty, and then filter the other symptom to make progress. So here, something that we knew about was the valvular pathology and what can affect multiple valves. So there were essentially three things that we were entertaining. One was the endocarditis, the rheumatic heart disease, and basically failure of any one valve leading to a domino effect. But how were we tying this in with the aorta? So we were thinking about this essentially as an aortic pathology causing functional valve failure. And now, before we came to the final diagnosis, we had really distilled this down into two things. What was the problem with the aorta and whether it was inflammatory? So there was no signal for any inflammation in this case. So we were really honing in on what are the non-inflammatory aortopathies that affect younger patients. So thinking of four things: the bicuspid aortic valve, Marfan's disease, Ehlers-Danlos, and familial dissection syndromes. And then, of course, we received the diagnosis, which really surprised us all. So thank you, everyone.
Sukriti, you're so amazing. That was awesome. Thank you all so much. Thanks for joining us. Hope you have a wonderful rest of your day. See you next time. Bye.